Alright, in this video I'm going to be discussing cardiac output. But before I get too far into the discussion, I want to go ahead and stress the importance of this topic. Whether you have an EMS background, you're studying to be a nurse, a physician assistant, on up to medical school, this is one of the most important topics that you must understand in order to be a great provider. Because essentially cardiac output is a great measurement tool that assesses your patient's perfusion or how well they're perfusing. For an example, if your patient's heart is really fast, or tachycardic, they're breathing fast, they're nauseated, they feel like they're going to pass out, they're dizzy, some sort of pain, all of these symptoms can clue you in that there may be some sort of cardiac output issue. So again, I just want to stress the importance of understanding this topic. So with that being said, let's go ahead and get right in it. So the technical definition of cardiac output is the amount of blood. Again, I'm going to abbreviate a few things here. Amount of blood pumped through the heart in 1 minute. So, in 1 minute. Now, technically, it's pumped by each ventricle in 1 minute, but in common practice, it's just said that you combine both ventricles as a whole. So, collectively as a heart, cardiac output is how much volume of blood is pumped through the heart in 1 minute's time. So, cardiac output has its own special formula. Again, something you must understand. It's very minor math, so all you folks that's scared of math, don't worry. It's if I get it, you're going to get it. So stroke volume times heart rate. So what does that mean? Well, let's first dig into what stroke volume is. Let's get into the definition of stroke volume. So stroke volume equals how much blood is pumped out of left ventricle in each beat. That number is usually 70 milliliters, so I'm going to go ahead and write this down here. Normal stroke volume in an average size adult is 70 milliliters of blood. So that's the technical definition of stroke volume. However, we really need to break stroke volume down even further to understand what these two words are actually saying. So break them up into the S and break them up into the volume. The S refers to stroke. Stroke refers to contractility or squeeze or inotropy for you you buffs out there. I'm getting ready to get into that term here shortly, but let's just focus on stroke for now. So again, stroke volume. The S refers to stroke. How well my left ventricle is contracting. How well it is squeezing. That's one of the fundamentals in this equation here. So that's stroke. Volume refers to simply how much is in my left ventricle. So far, breaking down stroke volume, it's referring to how well my left ventricle is kicking, its contractility, and how much volume is sitting there in the left ventricle before it contracts, so with each contraction. So 70 milliliters is our normal number here for this figure. So we've got 70 milliliters times HR. HR refers to heart rate. The average adult normal heart rate's around 60 to 100 beats per minute. So here's what we're doing. We're taking the 70 milliliters and we're multiplying that times 60 to 100. So just to throw a figure out there, we'll do 70 milliliters times 80 beats per minute. So that's going to be 70 times 80, which is going to equal 5,600 milliliters, or 5.6 liters. So that's good. That's what we want to see. That's in between our normal rate or range of cardiac output, which is 4 to 6 liters. Typically, men being naturally a little bit bigger than females, stroke volumes, cardiac output's a little bit higher. However, there are some pretty healthy females out there though, so their stroke volume or cardiac output can be relatively high as well. But 5.6 is what we want to see. That's within our 4 to 6 liter range with this. So again, cardiac output it varies directly with stroke volume or heart rate. So any change in these numbers is obviously going to cause a fluctuation in our cardiac output ranges. So I'm going to go ahead and move on to another page and keep breaking this down even further. Let's play with some numbers here for just a second, just to show you why it is so important to understand this cardiac output stuff. So go ahead and abbreviate that cardiac output. Again, that's stroke volume times heart rate. So our stroke volume, actually let's start with our heart rate. Let's say we have a patient and his heart rate is 171. Obviously that's fast. That's way out of our norm of 60 to 100. So heart rate of 171. Well, normal stroke volume is 70 milliliters. So that's normal stroke volume is basically saying 70 milliliters of blood in a healthy size or normal size adult is pumped out of the left ventricle with each contraction. That's normal. But that figure is based on a normal heart rate between 60 to 100. So the ventricles have plenty of time to fill with blood if my heart rate is between 60 and 100. So 70 milliliters, again, being the average figure there, the acceptable figure for a normal size adult, is fine in the normal patient. However, we have a patient now, his heart rate is 171. So that's going to cause a huge reduction in his stroke volume because the ventricles are going to have less filling time. Remember, the ventricles receive blood from the two upper chambers, the atria. There's going to be significantly less filling time now because the ventricles are contracting 171 times a minute, which is obviously way too fast. So that's going to take a toll on our stroke volume. So let's just play with numbers here, and let's say that our stroke volume is going to be 15 milliliters. Yeah, that's a huge reduction, but it can happen. So now we have 15 milliliters of blood for our stroke volume times our heart rate, which is 171. That's going to give us 2,565 milliliters, or essentially 2.5 liters, significantly less than our normal rate that we want to see between 4 and 6 liters. A huge drop, almost basically a double drop. So now you can see why your patient may be starting to get symptomatic. He may be starting to sweat. He may be tachycardic. Obviously, he's tachycardic. May be breathing fast. May feel nauseated. All sorts of symptoms that would clue you into some sort of cardiac output issue. So again, that's why it's so important to understand this. Now, that being cardiac output, that's the formula for cardiac output. Well, I got to throw another formula at you, but it's extremely important to understand this one as well. The formula this time is the formula for stroke volume. Just to remind you on the definition here, stroke volume is the amount of blood that's pumped out of the left ventricle with each contraction. Normally it correlates very well with the force of ventricular contraction as well, or the degree of stretch, which is the preload, I'll get into shortly. But the formula here for stroke volume, again, has its own formula, is going to be EDV minus ESV. So the EDV refers to the end diastolic volume minus the end systolic volume. Okay, so just to explain these terms, well, first of all, let me give you the normal figures. In an average size adult, our end diastolic volume is going to be about 120 milliliters of blood. Our end systolic volume is going to be about 50 milliliters of blood. I'll show you how I got these numbers here in just a second. So the end diastolic volume, that is referring to how much blood is in the left ventricle right before it contracts. So we're talking about a maximum relative capacity here in our left ventricle. If our ventricle is filling with blood, if you can picture in your head the point where the ventricle is finally filling with its last drop of blood right before it contracts, that is your end diastolic volume, which is 120 milliliters. Now, Big misconception out there. The heart does not pump all of the blood out that's sitting in its chamber. It only pumps out a percentage of it, which would be the ejection fraction, which we'll get to shortly. But our 120 milliliters, that's not our stroke volume. That's our end diastolic volume. Again, that is how much blood is in the left ventricle right before it contracts. Your end systolic volume is how much blood is left in the left ventricle right after it's contracted. So let's backtrack. Let's get back to our end diastolic volume. We're at 120 milliliters. Bam, we just contracted. Well, immediately when the heart relaxes, there's probably about 50 milliliters of blood that's left there in the left ventricle. So again, 120 minus 50 milliliters. Well, what number is that? Well, that number is 70. 70 milliliters. So that says 70 milliliters of blood got ejected out of the left ventricle. Well, coincidentally, that's stroke volume. So again, that's why 70 milliliters of blood is normal stroke volume in an average size adult. That's where that number 70 comes from. It comes from an end diastolic volume of about 120 minus an end systolic volume of 50 milliliters. So 120 minus 50, and there we have stroke volume on our patient. All right, so now I want to talk briefly about ejection fraction, since we're kind of on the same topic here. So ejection fraction, let me go ahead and erase this real quick. Ejection. All right, so your ejection fraction is the measurement or the percentage of how much blood is actually being pumped out of the left ventricle with each contraction. So it's percentage of blood. So got to throw another formula at you. Well, first of all, let me give you the normal range. The normal range for ejection fraction, depending on what book you read, but it's typically about 55 to 75% in most books that I've read at least. The formula for ejection fraction is we're going to take our stroke volume and divide that into our end diastolic volume, or EDV. Well, we know the normal rate now. We know the normal figures. Normal stroke volume is 70 milliliters. So if they divide that into 120 milliliters, should come up with 0.58, or 58% essentially. So what this is saying is approximately 58% of the blood that's in the left ventricle actually got ejected into the circulation. It's the percentage, again, there's a percentage of blood that's sitting in the left ventricle that actually gets contracted or sent out to the systemic circulation. So 58% that's what we want to see. It's within our normal range. It's 55 to 75%. That's exactly what we want to see. The reason it's important to understand ejection fraction, especially if you're in cardiovascular medicine, or you work in the emergency department, whatever capacity that you are, congestive heart failure patients. This is an important test that's used to help to manage, or I'm sorry, monitor the progression of congestive heart failure in a patient. Some congestive heart failure patients can have ejection fractions of less than 35%, even lower than that, 20%, 15%. I mean, we're getting really, really low here, but depending on how far they are into their heart failure, could depend on their percentage. So if you can imagine, if I have an ejection fraction of 28%, 58 or 55 to 75% is normal. That is a huge drop in the percentage of blood. So what that means is a lot of blood is left over because it didn't get contracted or sent out to the systemic circulation. So now my left ventricle is going to get really enlarged with blood. It's not going to have anywhere to go, so it's going to start backing up into other areas in the heart and to other areas in the body, which is bad, and it's part of the downward spiral of congestive heart failure. So that's just a quick spiel on ejection fraction. Now, the next thing I want to talk about is a couple of terms hopefully you've heard at some point. They're all used to explain stroke volume, so I'm going to go ahead and put that back up here at the top. Stroke volume. So The three terms that I'm about to use now are what affects stroke volume, or what alters the effect of stroke volume. The first term is preload. Preload is essentially referring to the degree of stretch. Of left ventricle. Left ventricle being the main pump that's responsible for the biggest duties. That's why we're referring to the left ventricle here. So again, preload, the degree of stretch. How well my left ventricle stretches and how far it stretches. That's our preload. The next thing, contractility. And I'm going to go ahead and write afterload down here. I'm going to give you the quick definitions of each, and then I'll explain them a little bit further as we move along. Back up to preload, talking about the degree of stretch. There's a famous guy out there, his name is Frank. This law that he has, the Frank-Starling law, is usually what we use to explain preload. Essentially what the Frank-Starling law says is the further you stretch something, the more forceful the contraction. So picture in your mind a rubber band. I know when we were kids we used to fire rubber bands at each other using our fingers. So think of it like that. Remember, the further you pulled back, the farther your rubber band would most likely shoot. Well, that's how the heart works when it's contracting. The more time it has to fill, or the more forceful the contraction, the greater degree of stretch, or the preload, the more forceful the contraction is going to be in that heart. So, guy's name is Frank-Starling law. If you want to research that further, go for it. But again, all he's basically saying with this law is the further you stretch something, the more forceful the contraction is going to be. Now, that's preload. Afterload is the resistance. I'm not going to skip contractility for just a second. The afterload is resistance against the heart, but specifically the left ventricle. That's what we're mainly talking about right now. So what does that mean? Well, let me draw a quick poor diagram heart. Well, I'm actually just going to draw the aorta. So we know the aorta kind of balloons up just like that and branches off into other great arteries that perfuse the rest of the body. So we'll say the one I just drew was normal. However, an afterload, or if you have an increased afterload, we've got a shrink in our container here. So obviously we don't have much room to work with here as far as sending out blood. We're very constricted here, or vasoconstriction is what's going on here. So the left ventricle, make that our left ventricle. So left ventricle pumping blood up through the aorta. If it has to pump against blood in that tiny container, is pumping against a very, very high pressure. There's a lot of resistance there in that container that the left ventricle has to pump against. Essentially, that's afterload. If you ever have an issue remembering afterload or how it works, just think about hypertension, because essentially that's what it is. People that have high blood pressure have a chronic afterload problem. Their blood pressure is always high, especially the arterial blood pressure is very, very high. So if the left ventricle has to pump against those tiny containers because they're not taking the blood pressure medication, your left ventricle is going to get weak over time, and a lot of things can happen as a resulting of that. One of the worst case scenarios is congestive heart failure. You can have that from chronic unmanaged hypertension. But afterload, resistance against the left ventricle. Again, pumping against a very, very high pressure. That's not good. That's going to make the heart muscle weak over time. So contractility. Contractility essentially is referring to squeezes the heart. How well it squeezes. A lot of factors can play a role in contractility. The first thing I want to talk about regarding contractility is, let me go ahead and erase this over here. Let's start writing this in green. I want to introduce 3 additional terms to you regarding contractility, because they all go hand in hand, and I think you'll get it once I explain these 3 terms referring to contractility. So, inotropy, chronotropy, and dromotropy. Inotropy just refers to the force of contraction. How much force is behind my contraction? How much force is behind my left ventricle when it kicks and sends blood to the systemic circulation? That's inotropy. Chronotropy refers to rate or time, but in medicine we usually just refer it to rate, over heart rate. Dromotropy refers to speed of impulse transmission. How fast an electrical impulse or stimulus gets to its target tissue or target cell. Now, in the heart, particularly with contractility, there's a lot of sympathetic fibers that innervate the heart, and a lot of them play a huge role in regulating how hard the heart squeezes, how fast it squeezes. So, the big neurotransmitters referring to the heart that plays a role in contractility is epinephrine and norepinephrine. So an increase in either one of those levels can jack the heart rate up, jack the squeeze up, or basically increase the inotropy, increase the chronotropy, and increase the dromotropy. So we're increasing the force of contraction, we're increasing the rate, and we're increasing how fast these individual cells talk to each other. There's a lot of other hormones out there that can also affect how well the heart contracts. I'm going to go ahead and erase this just so I can have some more room. Alright. So talked about epinephrine briefly. I'm just going to abbreviate that epi. And then norepi. These are the 2 big neurotransmitters that get put into play whenever the sympathetic nervous system gets stimulated for whatever reasons. If you're starting to have a reduction in your cardiac output, that's definitely going to stimulate a response from your sympathetic nervous system. So as a result, you're going to have these 2. They function at very different levels. Neurotransmitters, hormones, they have many different functions, but the response at this point, if we have a reduction in our cardiac output, we're going to try to increase the blood pressure, we're going to try to increase the squeeze of the heart, as well as how fast the heart contracts. So these are all agents that cause an alteration in your contractility, or how well the heart squeezes, amongst other things. So epinephrine, norepinephrine, thyroxine is another big one, and glucagon. Glucagon is normally produced in the pancreas, the alpha cells of the pancreas, to help increase the blood sugar levels in folks. Not necessarily diabetic. We all produce glucagon every day. Digitalis. Huge positive inotropic drug. And calcium. Calcium itself. Calcium alone, especially in the heart, has a lot of effects, but specifically it has a huge inotropic effect and a huge chronotropic effect. It's going to increase not only the squeeze, but also how fast the heart beats. So all of these agents I just listed, in some way, shape, or form, are positive inotropes, positive chronotropes, and they do have effect on the dromotropy as well, an increase in that. But the 2 big ones that we're concerned with right now is inotrope and chronotrope. So they're going to increase the squeeze of the heart, as well as increase the heart rate itself. Now there are some other medications and substances that the body produces that is on the negative side of the spectrum. They decrease the squeeze of the heart. They decrease the heart rate for various reasons. Some medications, such as beta blockers, which I'm about to get into, will have a negative chronotropic and a negative inotropic effect in the heart. So all of these devices that I'm about to talk about now decrease contractility. I'm going to go ahead and write that up there. Decrease contractility. All right. Acidosis, acid-base balance in your body. Excess hydrogen ions are a huge one. If your patient's acidotic, they have an excess amount of hydrogen ions. Excuse me. They may have elevated potassium. This is extremely bad. Potassium, particularly to the heart, really plays a role in slowing things down. Patients that have hyperkalemia or elevated potassium, whether it's from dialysis or some other function, elevated potassium, too much potassium will take a huge toll on the heart. It's going to decrease the heart rate, and it's also going to cause some significant ECG changes, which is part of another lecture that I'll get into another time. But drugs, big drugs that we're concerned with that we see every day is beta blockers and calcium channel blockers. So we just learned that calcium is a positive inotrope and it's a positive chronotrope. It increases the squeeze and it increases the rate of the heart. So if I want to combat that or antagonize that, I'm going to give a calcium channel blocker. I'm going to block the influx of calcium ions into the cell in hopes of bringing down that positive inotrope, bringing down that positive chronotrope. So everything I've just listed here is going to decrease the heart rate. It's going to decrease the inotropy, decrease the chronotropy. Beta blockers. Beta blockers work a little bit different than calcium channel blockers in that they act on the sympathetic nervous system. They are blocking norepinephrine binding at receptor sites, so specifically the beta 1 receptors, but there is different kinds of beta blockers which I really want to save for another lecture. But just to give you a heads up, some beta blockers are beta 1 specific, meaning they only control a certain area of the heart, or heart rate and the kick of the heart, everything to do with the heart itself. Alpha 1 receptors, if you stimulate them, causes peripheral vasoconstriction. However, there are some beta blockers out there that have some alpha 1 selectivity, such as carvedilol and labetalol. They're going to block the alpha 1 receptors in the blood vessels themselves and cause some vasodilation that way in hopes of decreasing the blood pressure, maintaining an adequate heart rate, and kind of decreasing the kick of the heart, and so it doesn't have to work too hard in the future. So these are just some devices, not all, or some substances, excuse me, that play a role in decreasing contractility, but not all. That's pretty much all I have for you as of now for cardiac output. I may add to this a little bit later of some other pertinent things that I think are necessary to go over, but hopefully you have a little bit better understanding of cardiac output. If this wasn't your first time, you may have had many lectures. Hopefully this at least tied up some loose ends for you. Stay tuned for another video on medications, most likely will be the next video. So hope everyone's doing well, and thanks for watching.